Thank you very much. And can I welcome everyone to this board meeting in public of Sussex Partnership NHS Foundation Trust. I apologise that we're starting later than the time that we advertised for this meeting. But anyone who's I know. Okay, can I please welcome Oliver Dale, and can I welcome Rob Jamansky? You're both welcome to the meeting this afternoon. Jessica, is this your first?
It is my first board meeting, as I've passed all of my fit and proper checks and have my official letter.
You are also very welcome as the representative of our universities.
Thank you.
Apologies for absence. I have received apologies from Pete Aitken, Nitin Mehta, and John Childs. Are there any additional declarations of interest that haven't previously been declared? It appears that there aren't. In terms of minutes, can I seek approval of the minutes of the meeting on the 7th of February? It appears that I can. Those are approved. I reviewed the action log. I believe we're up to date with the action log. Is everyone happy that that's the case? We are. We haven't received any questions from members of the public. We continue to promote that as an option for people, but we haven't received any matters. In terms of the chair's report, I will take that as read this afternoon. The two things I did just want to draw to the board's attention is that the Council of Governors did this afternoon approve the appointment of 3 new appointed governors from local voluntary sector and community organisations, and we will be sharing that information in due course. And we have also successfully interviewed for 2 new non-executive directors. And once we've gone through the proper checks, we'll obviously be in due course. But I just wanted to let the board know that we were successful, at least in being in a position to make some offers to people over the next few days. So can we now move, please, to the Chief Executive's report?
Thank you very much. Thank you, everyone. It's so nice to be in person. This is my first board in person at this trust. So I really say yes. So it feels really special, actually. So you'll see it's rather a long Chief Exec's report that has a lot of the national publications that have come out recently that I won't go into any detail of now, other than to say that they're there for information and that we are taking forward, and they will, and the appropriate actions from them will be reported through to the appropriate committees, such as the Quality Committee. But they're there so that everyone's cited on what's happening nationally. Rather than going through all of it, I thought I'd pull out a few highlights from the report, and the first being Chalk Hill. You'll remember that we got 2 improvement notices in July last year from CQC, and an immense amount of work has gone in place. I want to formally thank Teresa for her leadership in that area. And we had 2 improvement directors that came and supported us, Jonathan Warren and Andrew Mattin, who are both previously have been chief executives and one of the chief exec as well, and they've been working intensively with us. And Andy came to the executive team meeting last week and talked to us about the progress that has been made, and reported really good progress that has been supported by quality visits from the provider collaborative, as well as our internal quality visits. But obviously a recognition that there's still work to do, that we're on a continuous improvement journey. So it gave us some really good thoughts about what the next steps might be and how that we can continue improving and how we can share that learning across the trust. We're making progress in relation to the urgent emergency care pathway, and having had a peak in demand around Christmas and after Christmas, people waiting for beds, that has come down, but we've had those 11 beds in the independent sector that have been funded and that funding comes to an end on the 31st of March, and therefore we will be reducing our bed base by 11, so we're expecting a little bit of demand, but also at the same time we're looking at discharge and our medically ready for discharge, and we've had some movement in that area, and I've noted we've had a few of our really long stay medically ready for discharge, particularly in the west of Sussex, discharged in the last couple of weeks. And I think that's been a significant amount of work by the division with the local authority partners. But also the ICB chaired a discharge summit that really focused on the acute services, if I'm honest, but did keep mental health in mind, and myself and John attended, and we were able to keep talking about mental health. And as a result, we had a follow-up of the quality summit, and we had a second part to the quality summit that was with the local authorities, the ICB and us, to really focus on discharge and how we can do something differently, because just nagging each other and saying we've got a problem isn't solving it, because there are challenges across the board in the local authorities, in the health sector for placement. So looking at what we could do differently as a system and hold the risk across the system together. Over since the last board, we've had some significant movements in services, in that we have said goodbye to our Hampshire services, which you will all be aware of, and we've said goodbye to them really well. But we also, as of the 31st of March, are saying goodbye to the Lindbridge service and also our Sussex liaison diversion services. And we've been doing some work with them to actually celebrate the work that they've done with us and be able to say goodbye properly. They're obviously both the two that are leaving at the end of March still in Sussex. They're still part of our system and still part of our partners. So unlike Hampshire, where we sort of said goodbye other than the provider collaborative arm and CAS, these are still our partners and still people we'll be working closely with. So we've made sure that we really emphasise that to them, but do a really good transition to the new services. We've had our staff survey results, which will come through to the appropriate quality committee in more detail. We've had a significantly reduced response rate and a slight decline in our performance. But what we've tried to do is, because the survey took place at a time where we were restructuring, so you would expect some decline. The things that we're drawing out to work on is where there's been a steady decline over 4 years, rather than just reacting to what's happened this year. So those are mainly around compassion and inclusion, and the other one's about having a voice that counts. So they're the two that we're really going to focus on. And much like the findings of the community mental health survey when they come out, and the staff survey, we're going to tie it in with a lot of the organisational development work, rather than having lots of standalone action plans. Let's see it more as a strategic approach where everything is feeding into the same thing. I had the joy of, and a number of other people there, of going to the breaking ground ceremony for the Coombe Valley new build, which is really exciting. This is, and I was thinking about it when I was in there, this is such a big moment for the trust. This is a new build where we can really put our mark, and we can really make sure that our service users get the best possible care in the best possible environments. And it's really exciting to be investing so much money into a site and being there right at the beginning. And I think it's something we'll need to keep the board involved in and cited on as we progress, and not just at the end when we're suddenly doing the ribbon cutting. But I think we need to all be involved right the way through that journey. And I suppose finally, I want to acknowledge that this is Joe's final board. Thank you. It's been an absolute pleasure working with you, and you have been very close to the executive team and shown a very personal and professional interest into all of us. And thank you for that. You're going to be a loss to us. And also to acknowledge this is Peter's last. Yes, it is. Just a room. Last board today. And I mean, I think I'm going to say a bit more in private board, but in public board, I want to just publicly acknowledge this was my first chief exec's post, and I don't think I could have done it without you. You have been incredibly supportive. and you have been someone who has willing to let me just talk and be. And I think that has led to us having very open conversations at the board and be able to have oversight of what's happening in the trust in a really open and transparent way. And has felt like that we're on this journey of improvement together because of your leadership. So I want to formally thank you here, but I'll thank you properly later. Thank you.
I would like to make one comment. One of my first meetings at this trust, I said that one of the things I thought we really needed to do was improve the quality of patient facilities across the patch, and particularly in East Sussex. I can't say where it was for obvious reasons. The room burst out laughing because they had heard so often that it was a priority for this organisation to improve the quality of patient environments in East Sussex. And I think the fact that it is now happening, it's actually we're really now trying to make sure we are improving the quality of the estate across the patch is a major step forward, and particularly for that population. So, well, I think everyone should definitely celebrate. And as you say, they're learning to make sure it's worth having.
That's right.
Any other comments or questions? Executives report. Okay, so thank you very much. In terms, so I'm going to move us on now to the strategic review. And the idea here was that we were very conscious that we had brought each of the breakthrough objectives twice, except the final one, which is working with partners to improve the quality of life of communities we serve. So we thought it was important to bring that back today, but also I think, Colin, to take stock of where we are in terms of the year past, and then actually how we're going to make sure we make some momentum as we go into the year.
Yes.
Okay,
Thank you, Chair.
And on that basis, I'll hand over to you.
So people obviously have seen the reports in the packet itself. So obviously we're not quite at year end, but very close to it. And I'm pleased to sort of say that at the moment, of the 9 breakthrough objectives, of the 9 breakthrough objectives that we established as a board just over a year ago, 4 are being achieved, 4 are on track for achievement, and there is 1 that is unlikely to be achieved within the financial year. I'll come back to that, but is expected to be achieved in the course of 24-25. So just more specifically on that, and then I'll go into detail in terms of sort of the deep dive element of it. So the people measures are all expected to kind of sort of be on track, as was kind of sort of anticipated, which I think shows that we've had a much stronger focus on our workforce over the course of sort of the last year itself. The area where we have been particularly challenged has been specifically around our urgent care services. So we set quite an ambitious target around trying to look at reducing our vacancy rates within our urgent care pathways. And I think it's fair to say it's probably the area that we have struggled the most with. If you look at the graph on slide 3 of the slide deck, it actually sort of shows a trend upwards slightly towards the back end of back end towards December 23, although it has shown some more improvement over the more kind of sort of recent months. This will be being particularly picked up in our mental health urgent emergency care improvement plan, where we look to reconfigure and align our services in line with kind of sort of best practice, particularly around alignment of our blue light triage services and integrating those together, and also having a full review of our crisis response and home treatment provision as well, particularly aligned to the development of the community mental health model. So whilst disappointingly not looking like it will be achieved this year, strong plans are in place for achievement into next year. The area of particular focus then for this conversation today in terms of sort of is the partnership metric. So this is the one about working with partners to improve the quality of life in the communities that we serve. Pleased to say that everything is kind of sort of progressing well in this area. I'm going to do it in slight reverse order because I want to hand over to Dan in terms of the stakeholder survey in a moment. But I think, as we've talked about before, I think we've really made some really quite significant inroads into really understanding the kind of the housing and the accommodation needs of the people for whom we're here to serve and to help. And I think through the tenacity of our Associate Director of Housing, I think we've seen some really, really good improvements in terms of both housing related delays. But broader than that, you know, we now have a housing workforce within the organisation, integrated within our community and inpatient teams, that's really helping us as an organisation to recognise that actually early sight of housing related issues and early resolution can actually really help in terms of the sort of those kind of clinical pathways. We've got much stronger relationships established with our voluntary sector partners in this area, and looking at and in the process of developing some really innovative models, which are now starting to be held up sort of nationally as kind of areas of sort of best practice. So I think, you know, it's fair to say I think the housing piece for the organisation has really, really accelerated. In terms of looking at the remodelling of our workforce, so we've got quite a lot of work still going on in terms of thinking around how do we start to realign some of our workforce and work differently with our voluntary sector partners. The board will remember that we signed off a kind of a compact and agreement in terms of how we're working. We've got lots of work across a broad range of services, looking at how we sort of transition those posts across. I think probably the one thing to say as to why it's not been achieved quite as quickly as we had hoped, but is definitely on track for achievement, has been the kind of the bringing together of cultures. It's very easy to think about either the voluntary sector provides a service or we provide a service, and there's a sort of a gateway or a pathway in between. Actually, what we're really deliberately saying here is this isn't about an us or them delivery model. This is about a delivery model in partnership. And I think there's something about not underestimating the kind of the cultural piece of work, bringing together people who've either come up through an NHS career route, potentially come up through a voluntary sector kind of career route, and actually how do you develop a kind of a cultural overlap, particularly when you're thinking about things like trust, risk, clinical judgment, or hard use clinical judgment when we talk about non-clinicians as well. So there's lots of cultural work for us to take. And I think as colleagues will know, when we go on to the breakthrough objective for 2024-25, then there's a real intention to kind of accelerate that work forwards. And then the last area, Dan, can I? Sorry, you're opposite me. Dan, can I hand across to you about the stakeholder perception survey?
Yes, so we've launched the stakeholder perception survey with a focus on voluntary sector partners. The response rate is really low at the moment, and I suspect it's symptomatic of the pressure that our partners like us are grappling with at the moment in terms of planning for the year ahead. So to my mind, the sensible thing to do would be to extend that to one.
Yeah.
So we'd asked for responses in by back end of last week, and we've only got a handful.
I think it's fair to say at the moment our voluntary sector partners are particularly kind of challenged within the broader sort of system planning kind of sort of context. And I think that's having a sort of an impact. And I think what we're really trying to mitigate is that we don't have sort of slightly opposing narratives, if you like, where we're looking at strengthening our relationship, in essence, trying to divest activity into the voluntary sector because we see them as an incredibly important partner at a time where, you know, other things are being more kind of sort of constrained. So there's a slight juxtaposition that we kind of need to work through that. And then I guess the last comment I was going to make was just attached are the breakthrough objectives that we originally talked about and agreed back in November. I think there will be a need for us to continue to look at those, particularly in light, and I'll come on to the annual planning in the next item. But I think there will be a need for us to just test back against, as we land our kind of annual plan for next year and some of our priorities, actually, do those still work in alignment with the breakthrough objectives that we've established for the next kind of sort of 12 months, recognizing that there was a window of time in which we're establishing them for, or are there some areas that we may just want to just kind of go back around the loop, for want of a better expression, because actually our priorities are slightly shifting given the change in financial context that we understand. But that was what I was going to say, Chair.
Great. So it would be good to know if people have got any questions or comments on the working with partners breakthrough objective in terms of looking backwards, and then to sort of then start to engage with the question about that you posed to us in terms of do these stay correct in the light of the changing circumstances. Okay. Joe, so
Just think about timing of or intersection with the VCSE And I'm aware that the rest of the system is under pressure and where that our voluntary sector partners are a bit worried at the moment about it. I think, but that's possibly good timing for us to get involved in that it in terms of flow of resource and their ability to plan and their strategic intentions. Be a good time to.
I mean, every time's an opportunity, isn't it? I think there is an opportunity for us to not make decisions in isolation. I think we're at a time point now where we're really going to test what the system working means, particularly when you think you've got an ICB who needs to be looking at overall system financial balance, an NHS trust, and then the voluntary sector who have their own financial sort of challenges, and recognise that for majority, the NHS is only one flow of income. I think for us, it's going to be then very much about how we work really closely with them. And myself and the Director of Mental Health Commissioning within the ICB have a meeting, I think in 2 weeks' time, with the 3 place-based BCSE leads. And what certainly from an organisational perspective, we're really trying to encourage is let's go and talk about the scale of the problem and let's generate the solutions together, as opposed to going with a set of solutions and just try to get them over the line, because I think that creates perverse incentives in the kind of the way of working. So I think we do have an opportunity to really think about how we strengthen the provider relationship in a challenging commissioning context.
So my question is back to the culture, and linking it to the handful of responses to the survey. And I suppose I'm interested, number one, in the kind of soft intelligence and the conversations that are going on, the how's it going rather than the formal survey. Because I think there is a cultural difference even in how we collect feedback. We tend to be more formal, whereas perhaps in other contexts, there's more of an informal feedback culture. So I think we've got to move in that direction rather than expecting to pull people towards a formal feedback process. If we're going to do the things that you describe, which is to co-produce and to start with blank sheets of paper rather than here we are, we're the NHS and we're at the top of the tree. So I'm just interested to know what sort of conversations are going on, gather that kind of, soft feedback, intelligence, whatever you want to call it.
Well, I could start and see what will come in. I mean, I was just going to say, I agree. And the co-production process around our organisational strategy is a really important way of engaging our voluntary sector and other partners in a conversation and planning around our desired future state. Completely take the point about the survey. It's one metric. We shouldn't overplay it.
So I was going to say that I think you're right, and I think there's something about proof is in the pudding, and it's about working together. So if we look about our reduction in our memory assessment clinics, I went for a meeting with the chief executive at Sage House, one of the dementia voluntary sector services in Chichester, and they set up additional clinics for people waiting for memory assessments whilst we were doing this, and it was so successful that they're going to continue them afterwards. And I've got a half a day with the YMCA in Brighton next week with the new chief executive there, and I think that sort of forming relationships with key individuals in the voluntary sector, because we are such a big organisation and we are the NHS. It needs to become more personal, and then you get more of the sort of the softer intelligence that I think we're beginning to build on.
I'm really delighted to see the progress that we've made in terms of housing, because I think it's something that we've talked about certainly since I've been in there for quite a long time. I remember Peter and I making a visit to Helen and I and standing afterwards in the cold discussing what we need in terms of housing and what needs to happen. So I think it's just I'm very delighted, and it's great when Chris came and did that presentation for us. I'm also quite conscious that we need different types of housing for different service users, and just want to stress the importance of keeping that diversity of need in mind as we design the responses. But then picking up Anna's point about the difference in cultures of working with the voluntary sector, because quite often it does actually, and I know Kevin and I have discussed this in the past. There is something about us going out to them because it is much more of a talking culture rather than the pieces of them sending something formal. And if we get in the same room with them, we'll get much more information and richer qualitative information as well. So Dan, I acknowledge that we say it's one way of doing it, but nevertheless, I think even if we could find the resources of people who did just 3 weeks of going out and talking to all the groups in West Sussex, we've seen some very good input.
Yeah, no. So I think so absolutely agree. And I think one of the things we're starting to see is more conversation between ourselves, particularly things like district and borough kind of councils, and sort of voluntary sector kind of sort of providers, and almost we facilitated a couple of sort of summits sound a bit kind of grand, but conversations, roundtable conversations that sort of really start to say collectively, let's bring some ideas together. So rather than having a historic relationship where we design something in political isolation and we'll put it out to market engagement in that very transactional relationship, actually, how do we start to do the design piece together? Because frankly, we're probably there are other people who have expertise who will really bring something to the table. And I think the last comment, I think the going out there is really important, because I think the thing that we still, and I still trip up on all the time, is we forget that in the NHS, we organise a meeting for everything. Actually, in some of the we love them. But if you think about some of the voluntary organisations that we really want to engage with, particularly those that are really focused on particular groups of individuals who are disadvantaged in terms of how we configure stuff, they run everything on an absolute shoestring. So every hour that we ask to have a meeting with them costs. And I don't think we're always as sensitive to that variation in economy of scale as we kind of need to be, and therefore really make sure that when we get 5 minutes in front of someone, we absolutely ring it for its maximum benefit. And I do think that's probably something we could still significantly improve.
I guess without wanting to labour the point, I do just want to pick up. I've had stakeholder perception surveys over the last month from various big organisations, and just the survey itself gave me the perception that I didn't want to respond because of the size of it and the amount of time that it would take. So I'm always happy to run through, and it wasn't yours, but so I'm always happy, as somebody who is small resource, a small organisation, if you want to test something, but more substantively, what is the one thing we need to know in order to improve? So is there a question, so when we're going out, which is, what do you need us to know this year in order to improve? Because I think the way of asking that question will shift. If you have asked it, then great. But I've never been asked it by a commissioning body before. Just tell us off the bat, what's the one thing you need us to know? And it was a real treat when someone did it.
I wonder, Dan, whether that's a open door for us to test. We're in the middle of debating our sort of stakeholder questions to form part of our strategy development. And there's something about what we got to ask that's common of everyone, whether you work for us, receive services from us, work with us, etc. And then what are slightly more tailored questions, if you like. And there's one which is a couple of questions that's specifically around voluntary sector partners. So I wonder if that's an open door to test it, which would be really helpful. Thank you.
And could I just suggest that you add to that, asking them what's the one question you would have expected us to ask you that we hadn't asked you? Because that does come up, and actually, again, getting positive feedback.
In terms of the breakthrough objectives for the year coming, which we've obviously seen a number of times as a board, I suppose my only comment would be: are we confident we're looking at these with an equity lens? Because I think we need, it doesn't mean that this needs to change necessarily, but I'm always a little bit concerned that you can. I'm not saying we hide behind averages, but averages don't always tell you the full story. So some of these, I think, probably are generic, but some of them, it seems to be it's much more important to know who's engaging and who isn't engaging, who's responding and who isn't responding. I suppose it's just applying that equity lens in terms of how we interpret I've analysed some of the responses. I'm not looking to keep redrafting them. I'm just sort of checking. What do you, I mean, how do you respond to that?
I think it's a really fair challenge. I think we are still quite blunt in our understanding of things, if you like. You know, we tend to just focus more on kind of gross numbers rather than having that kind of, and it comes back to it's, you know, kind of comes back to sort of the data quality piece, which should never be an excuse for not understanding what's going on. But I do think I think there is absolutely something about actually through all of our breakthrough objectives, how are we looking at it through that kind of a quality impact lens? And then how are we sort of saying, okay, it's fantastic that you've got, if I just pick one, it's fantastic 20% of your care plans are co-produced and signed by patients and staff. But if that's 20% of people who are, you know, incredibly literate, English is their first language, and they live in suburbia within the Sussex footprint, that's quite different in terms of equity than actually if you're really saying, actually, for some people, we've really, you know, a number of these are through through translators, if you like. We've had to find ways of putting documentation into different languages, et cetera, et cetera. So I think it's a really, really fair challenge for us to take away and respond to.
Say Colin and I have also been talking about that very point in relation to the organisational strategy co-production again, because it would be very easy and convenient for us to be talking to people who use our services and families and carers who are connected to the work of the trust. And I'm downplaying or undermining the importance of their voice for a moment. What we need to do, as we've discussed here previously, is search out those seldom heard voices and really listen to what those people have to say.
Okay. It's just an admin question. So when the breakthrough objectives are done and the year is ended and we're in the next year, do we still keep an eye on the previous ones and punches of ones from the year before last?
So me asked that question in the exec committee this week or last week.
Some from last year that we still have.
So so I think it's an area that we probably haven't done quite as well as we could do. I think they've been a little bit.
We just forget about them.
So, no, I don't want to say forget about it, but I think there is that bit around kind of it's about continuous improvement, isn't it? Ultimately,
there's some connective tissue between last year and this year, which is great, and some not so much.
Yeah, and I think we've got to get better, if you like, in terms of that. We do these things because they're important. We don't do them because they're only important for a year. Do you know what I mean? I think you're absolutely spot on about that. I think we probably could think about how we build that kind of assurance over the
good narrative. Yes, to play back, isn't it? Yeah, we did eventually do the things they did.
In terms of the some of the things that I know that we're worried about. So it has felt like a year of changing goalposts in terms of expectations of different regulators through the year that we need to respond to. So when we then think about how the executive team in particular view the kinds of things they're worrying about, view the changing risks through the year, do these still stand up to a kind of reality check for busy executives that these still feel like the things we should be focusing on?
Before you answer that, Chair, may I and I think I just want.
It's helping me to ask this question.
Yes, it absolutely is, because I see Susan smiling, and I think about the discussions that we've had about all the efficiencies that we've been required to make, particularly since last November. And I think that ties in with this question about the importance of what we focus on, because it brings us back to something around our red lines as well. No pressure then.
Teresa, Collins.
So my comment was going to be that they're not in isolation. So
Sure.
we've got the quality priorities that we'll be talking about shortly. And those quality priorities that really talk to the fundamentals of care, that no matter what happens in changing context in the next year, fundamentals of care do not change, and they also will be priorities for next year. So really just to mark that point that the breakthrough objectives are exactly that, and that they sit alongside a whole range of other objectives that will be key priorities for us next year.
I suppose as the reality changes, we just need to check that we've got as many priorities as we can handle, given it seems to be given others as we go along. Osman,
I was just going to say it was a question that we asked ourselves in December, and I think given the targets in effect that we were set through the November process, they really just accelerate the work we're already doing. And so specifically the targets that we've got around reducing the vacancy rate in urgent emergency care teams, reducing agency spend, I think it all coincided that we're still focusing on the right things.
Yeah, and I think it's interesting talking to different organisations about whether or not people have put finance as one of their breakthrough objectives, and different organisations have taken different stances to it. My personal view is that this offers a really strong counterbalance, which keeps us very much focused on patients and quality. We will deliver finance, but we should be delivering the finances in pursuit of delivering the breakthrough objective, which is about delivering sort of the sort of strategy. And actually, if we don't, I'll just look at the ones for next year. If the first two are about quality and safety, aren't they? Fundamentally.
but they will help bring the money into line.
Exactly.
Sorry.
No. But and it's interesting, I think, because we talk a lot about how we make. I think one of the challenges as well, there's something about how we make decisions and do we have the right stuff. So the second one I'm really passionate around, which is the kind of the outcome measures piece, because we're inhibited in terms of making evidence-based decisions around where our best levels of effectiveness are if we don't actually have the information that helps us understand our effectiveness. Now you can look at it in lots of different sort of ways. So I think there's some not playing around. I think there's some reviewing them in the context of where we land to the overall plan for next year.
Yeah.
But I still think they fundamentally stand up.
Kevin,
It's going to be a kind of complement right into the to alongside the executives, because there's a huge change this year in the nature of the breakthrough objectives. They're enabling objectives, aren't they? They're more about internal stuff that's going to be transferable and be useful in the future. And there's a lot of knowing in here, trying to find out. So I think they do underpin any sort of financial reshaping, right? We need to know outcomes, we need to know deprivation.
anything else on the breakthrough objective or the breakthrough objectives for 24? So I think that we had a good conversation about the way in which we're managing to change the quality of the engagement with the voluntary community sector. I think we see them as really. I mean, one of the things that was always said to me when I arrived was that the voluntary community sector didn't feel they were treated as equal partners, and I think that narrative has changed significantly from some of our voluntary community sector leaders, and I think the way in which we're taking a more relational approach and the fact that we're trying to co-produce solutions to problems with them is clearly will stand us in stead to try and face here. I think we've received assurance that in terms of the breakthrough objectives for 24/5, yes, they do feel still very relevant. They don't sit in isolation, and that actually we are taking a quality improvement approach to helping us get to a more sustainable financial position, and that clearly we want to know more about what's going on within the organisation. I think that part of that is to make sure we're looking through an equity lens in terms of who we're reaching and who's achieving. So thank you very much for that. Yes, please.
Sorry, you asked whether we had anything on the 24.
Yes.
Can I make one point?
Yeah.
So just
Let's call that an interim.
sorry.
Let's call that an interim summary.
I'm so sorry.
Is there anything else on the 24/25 breakthrough objective?
Sorry, this is just something that's come up at quality, and I feel it's worthy of just noting here on page 4, the routine use of outcome measures. And in the problem thing, you talk about services and clinicians do not consistently collect and use patient. Now, so my question really was, how are we involving clinical teams in this? Because there's a worry for me about making a problem statement that we know most clinicians understand and been challenged by for decades. So I just wonder if there's some way we can slightly modify the language that doesn't suggest to clinicians that they haven't been doing a good job up to now, and suddenly there's a new problem, because this is a problem that has been around for as long as I have been involved with the NHS. Getting good outcome measures is not an easy thing to do, and I would just like the language to reflect the complexity a little more. Just sorry to be awkward, but that's my job.
And that's, but I was just going
I might not be able to answer that
your
question
bailiwick.
exactly, but I was just wondering if it might just help me to say a little bit about what's happening in the community transformation programs. It's just one example of a partnership. You hearing it, so I'm having a slightly trouble with it. But anyway, that program is co-chaired by the VCSE themselves, and at every level of it, each meeting is similarly led by a partnership. And on the ground, the emotional wellbeing service is established 30 out of our 39 PCNs. And those services are a marriage between traditional clinical backgrounds and VCSE colleagues. And the experience has been extremely positive. We've had surveys across the county, and it's really provided us the platform for the next phase of community programme. And that's only just one example of those sort of principles are there in the other areas of transformation as well. And it's really is through new relationships, new ideas, a very different way of thinking. So it's very positive. And going back to the point around the changing goalposts, a lot of the plans that we've developed through those partnerships, I think simply we're just accelerating them really. So we've been talking about the moving away from having so many inpatient rehabilitation beds and developing the estate to partnership with housing providers to create residential placements. And again, that will be something that's not led by clinicians. That will be, again, a partnership with colleagues, I'm assuming. But to I think actually it has moved on quite considerably.
Thank you. So, I understand what you're saying, but there is a reality to it in that services are not using it, and without it, and I wonder whether it's I don't know, something like outcome data is not routinely used to improve quality and take out the services and clinicians. That makes it more generic, because I think we need to be honest and say, and you've said it's true, it doesn't happen, but take the sort of who it is out of there. Would that be right?
I think it's that's you know, it's so in a sense you then,
I don't want to water it down, but I don't want to blame. So
exactly. So, but you're not facilitating achieving your goal, but if people feel blame, that's really
because it's a lot more complex than services and clinicians. It's about how we record it, it's how we and it's the agreement and how we use it. So if we can make it more generic, so that patient outcome data is not used collected and used consistently to improve quality, something generic. Thank you.
Sorry.
Thank you. That's really helpful. Thank you. Any other 24, 25? Yes, it is fine if there are. Let's check.
Looking forward to the outcomes.
Okay, thank you, Colin. I mean, it's I think also that progression from the 23, 24 to 24, 25, the fact that it's set in the wider context of the challenges with this, I think is reassuring. We're still deliberating, but it's good to hear that those conversations are developing in a way that feels rooted in reality and ambition. Okay, thank you very much. Can we now move to quality and safety? The plan, well, that was the 24.
Oh, right, sorry. Oh, wrong was it? Sorry, because it says this one.
You've got the old agenda.
Sorry.
Yeah, this is the advanced agenda, where it says annual plan comment.
I won't interfere. I won't interfere.
Okay. Very happy to be told.
Oh, sorry.
Okay, no, help is good. Help is welcome. I don't want to discourage. Don't want to discourage help. So we're now moving to quality and safety. And the idea here is that we have our normal from the quality committee. And then we will then, as we move into next year, we will focus a bit more in board on equality improvement initiatives we've got across the organisation, and that obviously relates both to quality of service and people culture. But for today, we're going to look at the specifics listed here, but that's the idea as we move forward. I'm not sure if I made that better or not, but you know, I'm not sure I forget. Anna.
Thank you, Chair. So I'll take the report as read. I just wanted to very briefly give the board assurance on the 4 reports that you have appended to the quality. So just very briefly, and then I'm going to invite Teresa to come in with any more detail. But on mixed sex accommodation, we have a clear plan to eliminate breaches, so we are not there yet. On IPC, we have good overall compliance against national standards, incredibly important, but again, lots of work ongoing in relation to controls. So that is work in progress. On learning from deaths, we have a downward trend since February 2023. Good progress on physical health checks, but not there yet. And I think finally on that one, you know, the work that's ongoing on integration of data from different sources, triangulation, in order to understand more, in order to learn and improve more, is very much what we talk about at Quality Committee. And I think I can give the board assurance that that is what is in work in progress. And on Guardian of Safer Working, again, as I'm sure you've read, assurance that standards and compliance is being met. In terms of other updates, I think I just want to note again the work that's very central to the Quality Committee is looking at improvements at Chalk Hill and learning for other services across the whole of FPFT. So certainly one of the things that is of particular note and concern is the lack of availability of capital funds for 24-25 and its associated patient safety impact. So we have Teresa chairing the capital prioritisation group, so things are progressing there, but certainly we are concerned about that lack of availability. I think we're beginning to see an impact of PSERF on reporting, recognising that it will take time because it's a very new system, and mindful of the significant changes both locally and we're seeing that nationally as well. Quality priorities are taking shape. More work to be done there, and you will hear more after April. I wanted to just draw the board's attention to the continuing improvements in the number of social workers employed by FPFT, which is now at 175, and the assurance that we received that that new members of that team are well supported and increasingly well integrated within multidisciplinary teams. And finally, from me, we heard from the People and Culture Committee that there are no new risks there, but I'm sure Funmi will update us shortly. Stop there. Happy to answer any questions and then to Teresa.
Thank you very much.
Could I just add to that, Anna, okay, that we did talk about the Mental Health Act and Mental Capacity Act Committee, and I think it's getting kind of urgent now that we reform it. We're running, say, the 21st of May. But so in terms of reference, we're going to be reviewing it, but I think we need to put a bit of effort.
Thank you.
It was just an observation. There's a couple of points in the report I've noticed in terms of there's a learning from deaths and audit that Peter was going to commission in relation to care plans and medication. And then again, the social worker best practice and looking at outcomes. That there were a couple of statements that seemed a bit open-ended, and I'm sure that we've got them plumbed back in to either come through or to the respective governance. I just wanted to be sure that we had closure of those two items so we don't lose sight of them, because from a regulatory point of view, it'd be helpful just to track progress through some of these things.
We can pick that up, Rachel. I'll have a look at them.
Thank you.
I'm sure that they're on our action plan for QC, but I'll check.
Thanks, Rachel.
I have some question. Is, guess, given the concern about the capital spend, and its relationship to patient safety, what questions should we be asking in 3 months here at this board in relation? Because the money is obviously a reality, but it's easy, isn't it, to note it? And I guess it's what do we need to be asking and checking in the next period?
Thoughts?
Well, let me cover it from one perspective and then Teresa can cover it from another perspective. So I think part of the answer to that question is how we've changed where it sits this year. So historically, capital has always sat under finance, with the CFO chairing that process, which I think that's something, I've always found slightly uncomfortable because it didn't feel like the right place to necessarily do that. So this year we've changed that. So Teresa will take on the chairing of the capital prioritization to make sure that it is quality that leads the prioritization piece. I think the questions that in 3 months' time that you might want to ask us is when we, at the next extraordinary board meeting we have where we can talk about the plan, that will also include the capital. Talk about this is how much money we've got versus how much money ideally we would have liked.
Yeah.
We'll try and set out, although it possibly won't have been fully finished, what that prioritization process will look like. And then in effect, the choices that we've had to make, like all NHS trusts at the moment, is well documented. There is no one who has single capital they need and backup maintenance requirements across the NHS. I think continue to be challenged. And I think the challenge for us will always be, have we prioritized those areas that are of the most risk? And having done that, what's left? And then I guess that's where the challenge comes in. It's if we were unable to carry out those, why would the most high risk things? Yeah, that would be the question. Is what would we do about that?
And then what I would add to that is that through the capital prioritisation process, we're strengthening our risk register and our risk assessments and the controls and mitigations that we have oversight of through the capital prioritisation process. We've developed a prioritisation tool so that we've got good governance around the decision making that allows us to be clear about how we're deciding to use the limited funds that we have. And we've escalated through to NHSE, who have shown a particular interest and are now asking a number of provider organisations to share information with them, with a particular interest in ligature and states requirements that would help us to address ligature risk in instances where there isn't the associated capital fund. And I think to Usman's point, this isn't solely SPFT, this is a risk across organisations that we've illuminated, conversations with NHSE.
And can I just build on, I think this is something we need to keep asking, because this is not a problem that is just ours. And yet it's, the danger to people is significant. So I think we need to be bold about asking that question.
And I think that's the bit which always interests me, is because it's widespread, it can be easy to get to think, oh, it's happening in other places as well. And so how do we make sure that we say even louder? Because
And it's on about.
Okay.
Okay.
Yeah.
So our patient story there was really interesting, wasn't it, in the context of the mixed sex accommodation and the declaration. So as I said earlier, we are in the process of updating the leaflet, and we'll be very clear in the leaflet about what our transgender patients can expect in terms of their admission to any of our facilities.
It'd be really helpful. You can see how much stress that would be.
Yeah, and that is the national position, so that needs to be our position. And I just wanted to link it to Coombe Valley, because Coombe Valley Hospital will have 54 ensuite bedrooms and is in the geography of our patient that we heard from earlier. So it shows, doesn't it, just how important that updated estate is to
Yeah.
allow us to deliver the practice that I committed us to earlier. And I just wanted to highlight that link. So Coombe Valley, 54 ensuite bedrooms in the area that our patient resides, in a conversation about the needs of transgender patients, and our ability to practice relies on us having a fit for purpose estate.
You know, I just wanted to say that there's also something around how we then disseminate that information
Yeah.
effectively across. So we're not just holding that knowledge.
As other VPs don't.
Yeah.
Possibly. So I just wanted to pick up on, if I may, on Chalk Hill, and I don't want to ask the committee to rehearse the conversation it's already had. But I suppose as a board, we probably need to think about how do we assure ourselves that the learning from Chalk Hill is being the organisation, and are there things that we can learn from our previous experience, but when that hasn't happened, in terms of how we then move forward. Don't know, but
So can I just ask then, is it something that you feel the board would like, for example, have a more of a deep, a more detailed update at some point?
yes,
Because that would be the obvious way to do it. So, reporting that it is being done at quality. But I think what you're asking is give us more granularity and more detail about how and what. And I think that needs a longer discussion.
I suppose I'm very aware that when CQC reported, they did question whether there had been proper governance, and I know that is something that the Quality Committee has been discussing. But I just need to check that the board is right to delegate that
Yes.
to the Quality Committee, or whether it should retain some of it to itself, given the seriousness. And I suppose that's the
My
question.
view is that it's twofold. So I
Yeah.
think absolutely there is an assurance process through QC, but I also think that there is more opportunity for the board to have further conversation together around the learning from Chalk Hill that allows us to feel assured as a board that you hear me use the analogy of the sponge, rinsing the learning as best as we can across the whole of the organisation. And I think there's more that we can have a conversation about in that regard.
Yeah, and it may be that actually as part of the board development, membership of the board is never static, but now the board is sort of coming together in its current full membership. It might be useful to use it as an example of thinking about the way we look at quality. It can help everyone have a shared understanding. Maybe that's the lens.
So, and then within that process, use it as a good way to look and educate and raise an awareness across the board, particularly for the NEDs around accountability
Yes.
and
Yes.
things to think about.
So rather than doing specific training, you actually use some case examples and working through, which might be helpful for people at all stages of drug development. Didn't mean for that idea.
But it's that report that counters the Chester one, they build a learning center, use that.
All right. Anything else on the committee report itself before we move? Okay, so Teresa.
So the only other thing that I wanted to say in relation to quality is that we're in the process of writing our quality account for the year, and that will come to board in June. Within the quality account, we'll be reflecting on the quality plan of this year and our achievements against the quality plan this year. And we'll also be reporting on the quality priorities that we propose we're setting for next year. Now, many of you would have already heard me say this, but from a quality priorities perspective for next year, we are absolutely focusing on the fundamentals of care. So you can expect to see much more about that in June board. And to Kevin, to your earlier point, how do we not lose last year's plans as we're developing this year's plans? An example of that in the quality plan would be our management of ligature. So ligature featured highly, specifically anchor ligature on inpatient wards featured highly last year, and it continues into this year. So we're continuing to work on our ligature management and care planning into this next year. So we're not losing last year's priorities. That's all that I wanted to say.
Okay, thank you. And then we need to note the compliance with eliminating sex education.
Yeah.
Infection prevention and trouble insurance framework. Yes, safe working. Can I check, please, under the learning from deaths? If I've read it correctly, then our old friends record keeping and physical health checks have come through again. This does feel a bit like we've been here many times. How are we confident we've now got this on the right improvement trajectory?
The mortality reviews.
Yeah.
So I was speaking to Teresa earlier about this. There's a bit of work to be done. Partly because we've also got the medical examiner developments to incorporate into the process. And I'm meeting with Lucy Frost, who's newly appointed, to think about the mortality review process as a whole. I'm assuming you're referring to the thematic analysis of the different learning, and yeah, I think it's there. Yeah, there's some improvement to be seeing.
Well, I think I go a little bit further than that. Maybe Jane, you could come in, but it feels like we've been here before, where we've identified as a theme record keeping, we've identified as a theme physical health. It's just checking why it's still emerging as a theme, just to understand that.
So it's really interesting because as a group of chief execs, we had a conversation this week actually across Sussex about areas of performance that were stuck in the system, and there was a wondering about why, as a system, we are able to do the physical health checks for people with a learning disability, but we aren't able to do them for people with SMI. And bearing in mind, this is a primary care responsibility, it's not an SPFT responsibility, but I was asked if we could provide some expertise and consultation into that process for the system to think about how we increase the needs of the system-wide performance challenges around physical health checks. And I think that puts another lens on our physical healthcare work as well, because it's sort of, as we're talking about it in the system, we have to get our own house in order a bit more. And I know that Teresa's been strengthening her team in physical healthcare and thinking about the needs in there. So I think there's work in train, but there's still work to do. But it's not just an SPFT, it's a system-wide thing that we need to look at.
Did I also read that the method of recording is changing, that it's going to be drawn from primary care records next year? Did I misread that? According to the...
It's already drawn.
Okay.
I think it's already drawn.
So it's a GP recording sheet.
Yeah. I think just to let the board know that particularly related to physical health, but also linked within the medical staff recruitment and retention. Peter Aitken and I had a meeting and we've got certain ideas to take forward. And what we've arranged is regular meetings to see how we can build on that. And I think in due course we'll bring that back to the board to share the next steps, because there are and I think I've mentioned it before in the board that I've got a sort of publisher lined up who is willing to publish Sussex monographs, which would be PhDs of students from nursing or psychology or, if they want sort of, and that would be one of the rewards, as it were, but also more in terms of mentoring, supporting, and working with the medical staff to support them so they can then support others.
Thank you. So we note those 4 reports. We nothing to escalate. Thank you very much indeed. From me.
No, it wasn't a question. I was going
No,
to,
we're going to people and culture.
yes,
Yeah.
yeah, I just wanted to double check.
I can go to someone else.
Yeah. Very, very ready and very happy to cover. And so as you will see from the paper that we have submitted, we decided to focus this time on talking about our recruitment and retention initiatives. And just to give a very quick overview to the historical position that got us here. So we started the financial year with a recruitment vacancy position at about 17%. And our turnover was also at around the 16-17% mark. The trust improvement plan at the time had a 3-year trajectory to bring our vacancy down to 14%, and same for our turnover. And so that was the overarching plan, but knowing that within our clinical professions, so our nursing and medics position, we were holding a vacancy of about 30% for our nursing professionals and 28% for our medics. So that's just the landscape in terms of the layout of what the position or the issue was. We've then had a significant number of initiatives, and over the year, and I won't bore you with all of them, but the point of the overview today, as we come to the end of the year, was to allow us an opportunity to look back in terms of what has worked, but also to say going forward and to provide some assurance to the board on where we sit across those initiatives. So I hope that that approach is one that does make sense. In terms of our recruitment, we are now sitting on a trust-wide average recruitment position of 12.98%. I'm very happy to be able to report that to the board. We still have the specific hotspots within our professional vacancies with our medics now down to 27%. And I'm reporting to you live data. So this is February end numbers I'm providing to you as of today. So that's 12.98 trust-wide. Our consultant position has moved just a little to about 26, high 26%, and our nursing professionals, and you'll see from, we've reported this at our quality committee, now sits at the high 25%. So it's the first time, I understand, in multiple years that we've been able to shift that 30% vacancy. Now, behind this is a significant amount of work within our local leadership levels, really exciting, innovative things that have been tried, the new roles approach in terms of looking at skill mix changes, and so on and so forth. So I wouldn't want to say it was one thing that was ultimately responsible. A very big impact has also been our international recruitment program, which as of the end of February had seen 109 nurses come into the trust in the last 2 years. And just to put that into context, the international nurses report a 6% turnover, but that sits against our nursing specific turnover, which is in the high 20s. So again, just to show that that was a scheme that was supported, funded by the trust, very expensive, and we'll come back to that later in terms of why we've decided to pause that for the coming year, but has been very effective. So with all of that background, looking into the new year, we are holding a position knowing that we're going to be having significant transformation work. We're holding a position that will keep us aligned with the region in terms of our vacancy targets, but the activity that we're working on with regard to retention, and I'll just talk about that for a few moments, is around our recruitment and retention incentives group. So that is chaired by John Child, who's our COO. And the idea behind that is to, back to the OD and the communication part, is to support the organization better in not feeling helpless. So we're bound by what we have to pay people, but we're not bound around
the incentivization and being really innovative in terms of how we can do that. So there's a recruitment intention group. In the last year, 96, just about 100 submissions have been received. 81 of those have been approved. And I think what that says, and I like to interpret that as those would be 81 additional people that would have left if we hadn't found creative ways to keep them. And we have 34 of some of those initiatives currently still active. And that then also has some further areas of improvement, which you'll see in the slide deck. The other key part around retention is around our well-being offers. So that is one area. So we have a significant amount of health and well-being offers. And again, I won't go into the detail, but you will see that there's a massive amount of that. And one of the things that I and the senior team have reviewed was around the uptake for that. So we have a very good, what I consider a very good offer. The uptake is not great. So that means actually that the work we need to be doing in the coming year isn't to amass more well-being offers, but actually to ensure that we have a better way of communicating them, empower our middle managers to offer those to their staff, and recognizing that when it comes to retention initiatives, it is not only about money. So it's that just changing the dynamic around that. And then finally, I wanted to talk about CPD, which is a hot topic, and that's our continuous personal and professional development, knowing that within the scope of our limited financial cover, how do we support people to continue to develop and to learn? And our ODPA is a great part of that. Our Leadership Plus, which is a new offer that we've put into place to provide and support people, but also to look at the funds that we do have, because it's not that we don't have any money, it's to look at what we do have and say, how can we really make what I've been telling people now, the best bang for our buck? So how can we get the most out of that? So I'll stop talking. I'm very keen to take questions and feedback, but it was really just about playing back to you what we've done, what impact that has had. And that's why I like to talk about numbers, because it's really tangible in terms of the impact, and then what we plan to do in the coming year. And then you can offer some check and challenge around that.
Thank you very much. Are there any questions or comments for me? Simon.
And great to hear about the progress, and to agree with you about not offering more and more, but making sure people know what there is. But I think there is also some emerging evidence which people often say that the wellbeing offer needs to be better. But actually, if work conditions and environments, the risk is that people are saying they want a wellbeing offer, when what they might be doing is say, I want my working conditions to be slightly different. And I think given what people have been through for the last 4 years or so, we mustn't underestimate that. I guess my question was whether the staff survey, whether there's anything that jumped out in that sort of first look at the things that have happened over the last 4 years, which also directly impact around the retention piece. And so earlier, I think you said there were 3 areas of improvement, 19 areas of decline, and I just wondered whether there's anything that we learned from that survey which aligns with the recruitment strategy for the year ahead.
Absolutely. I think one of the biggest things that came out for us was that we were seeing a systematic decline over a 4-year period. So there wasn't one big jump in one area, it was just that slow chipping away. But the one that stood out the most for me, and I think a lot of our senior leadership team, was the third area that we want to focus on, which is engagement. So we've had a significant decline over 4 years in we're compassionate and inclusive, we each have a voice that counts, and around engagement. If I pick we each have a voice that counts, and we pick up the thematic feedback and the comments that we receive, it always boils down to people not feeling heard. But that's really about the experience, in terms of the experience, and that sits at the heart of retention. So I experience something, I fit it back, I don't get the response either I expect, or one that is compassionate, empathetic, or understanding of the situation. I have a poor experience,
I'm on my way out. And that's the beginning of that vicious circle that we then need to unpick. And that's why the approach this year is not the action plan approach of we're going to now do 67 actions for the 67 things we did poorly, but really to look thematically to then say, how are we about the business of changing the experience of our people working with us, and what that means is taking an innovative mindset and approach to problem solving. So yes, it does really sit within that retention strategy.
Thanks very much. Thank you. And particularly, I'm delighted that you're paying attention to well-being. And just a thought, we did a survey of the sort of medical staff and medical students, and the rates of burnout were really, really horrendous. And we then went international, and the rates again were between 65 and 90%. So, I mean, I think the fact that we are kind of looking forward and planning, that's really good stuff. But the question I have is whether, as a result, we've developed a charter for mental health and well-being. So whether the trust would be willing to look at it, sign up, and take it forward as a kind of Sussex charter, which can then be used by other NHS organizations.
Yeah, can I just ask to clarify? You don't mean 65 to 90% of people experience clinical burnout, there's symptoms of burnout?
Yeah.
Okay.
I'll be very happy to
Okay,
take that,
that-
yes, to take that
Yeah,
forward with you. But we do belong to the Sussex sort of well-being team, and I'll be very happy to bring that into part of the
That'd
conversation.
be great. Thank you.
Okay. Oh, sorry.
And
I'll go first. Yeah.
So I think this is great. It's so good. I mean, this is really heartening for all of us to hear after all and all the work. Credit to you from me and the team. I just wondered whether there was some way of capturing the sort of progress. So you've got this really clear staff health and wellbeing framework, emotional, physical, financial, and you've got some numbers in there. But I kind of, maybe this is something for quality committee, just to see some of those trajectories of increasing numbers, or something that says here's the direction of travel on some of these. Just because I think people will be really heartened to see the uptake.
Mm-hmm.
And just a very quick one on where is spiritual well-being in here? Because I remember we used to have an updated quality committee about, because there's some fantastic work going on, on that, but across in all sorts of different places in SPFT. But it felt to me like just something to acknowledge as well, because I think however you define it, it's something in there about the activity that goes on. Just a small thing.
The wellbeing report is diarised for PCC in April, so it'll be coming to QC with a proper year-end analysis of uptake and the cost as well. And spirituality one, I'll take that away.
Okay, thanks for me. Joe.
Amy,
I'm really heartened by the approach that we're now adopting in terms of how we respond to the STAR survey. Because several people around this table have heard me say each year, it's not about the survey, it's about what we do with it. But in terms of the work that we've done in the last year around this whole area of staff retention, voices being heard, and connectedness, I think, and this is what I said to you one-to-one recently, I think it's really imperative, but particularly I come from a corporate background, and I think that the thing that always makes sense is to link what we're doing with the strategy and the financial drivers, so that if we improve retention for every person that we hold on to, there is a cost attached, isn't there? And what the difference that makes in terms of the patient experience, the colleague experience, and the career opportunities that are open to people when they stay with us. And I just think that we, and also the NHS more widely, is not very good at actually positioning and communicating in those terms. Because when our managers feel that
they've got enough on their plate and they're coming in with, now you want us to look at compassion and engagement. Well, actually, the business driver is very much about if we keep these two people rather than losing them and going out recruiting, and we spend the money, it takes another 6 months to get return on our investment. I would like to encourage us to really move into using that sort of language to also shift managers' behaviour in terms of why we need them to get on board. It's not a nice to have, it's a must do. I'm nearly gone.
It's a very, very good point. And it's always about what the cost is to us of not doing what really is a must do. So, and it's just how we message that and support building that resilience into how we think.
Oh, it's even more than that.
It's
because
more
it depends on the level of person that you're placing. So that might be for HCAs, but you know, it builds on.
Any other? So for me, I think you've heard that we're very supportive of the approach that is being proposed here. We're looking forward to seeing the kind of the charts that show us the progress, but also I think, as you're saying, that the importance of them communicating that to the organisation, because I think there's something about communicating and optimism here at the moment that you're talking about. Clearly, there have been some very specific points about how we engage different parts of the workforce in terms of making sure that they understand that we are serious helping with well-being, because that then obviously improves outcomes. It also helps us with retention. Clearly, we need to understand that as part of the financial recovery, it's very important both to the quality of care to bottom line. So I think everyone's very much looking forward to you reporting on these through the year, but I think there's a huge amount of support for the approach that this articulates. Thank you very much. I look forward to seeing the year-end data. But I mean, I think as Joe rightly says, and Simon as well, I mean, we have often struggled so what question around the staff survey, and I think this does start really starts to answer the so what, so that's really good. Thank you very much. My sense is that we need a little break. I think we need to get up and move around. So those that are watching on the live stream, we will be 20 minutes break. So perhaps if we could sound the sound and picture off just for that 20 minutes, and then we will be back online